From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson. Today is Wednesday, March 12th, 2025. The American Society for Clinical Pathology's annual Lab Week is coming up soon, and is our tradition on this podcast. We like to celebrate all of the great achievements of our industry with an episode that embodies each year's unique theme. Now, this year's theme is Mystery Machine of Diagnostics, Another Case Solved. So we're going to talk about mysteries today. Today's LabMind guest has a lot of experience solving medical mysteries. Amanda Openshaw has a master's degree in genetic counseling from the University of Michigan and is certified by the American Board of Genetic Counseling. She has worked for ARUP Laboratories since 2007. Let me also note in advance for listeners that we are going to talk about some patient cases today. These have been de-identified by Amanda by altering some of the details in order to protect patient privacy. Amanda Openshaw, welcome to LabMind.
Thanks so much for having me.
So what is it about genetic testing that requires a mystery-solving sort of detective mindset?
Well, in a laboratory setting, you are not the individual who has a relationship with the patient. You haven't seen that patient face-to-face, and you may not have all the information about that patient that's pertinent to the genetic test or any test that's ordered. In genetics specifically, it's important to know some more details about the patient because genetics is more complicated. It's not one size fits all. There are lots and lots of options to pick from, and it takes a specialized knowledge of genetics to be able to sort out the right test. Not only a knowledge of genetic conditions, but genetic methodologies and a particular lab's test menu. So the mystery comes in when you get a test order without any information, and as a laboratorian, or in my case, as a genetic counselor in the lab, I'm trying to figure out, okay, what was the clinical diagnostic question that the doctor was hoping to answer, and is the test that's ordered right now the best avenue to answer that clinical question?
So one argument that you could make here is that it's the physician's job to order tests, and that each individual physician has the responsibility to have a deep knowledge about not just their patient, but also about the tests that they're ordering. And if they don't have that deep knowledge, then they either need to go educate themselves or they need to refer the patient to maybe a geneticist or someone more expert. Is this a realistic perspective to take?
I think in some cases, absolutely. It's realistic for the geneticist to be ordering the genetic testing. But what some folks don't realize, even folks who are trained in clinical genetics, is that not all genetic testing is ordered by geneticists. In our healthcare system in general right now, there's a push for more personalized medicine, more genomic medicine, and genetics is creeping into all different avenues, all different specialties, not only because of the push for genomic medicine in general, but also because there's a lack of genetic providers in this country. So geneticists, I did some Googling. For the sake of estimation, there are maybe 1,000 or 2,000 clinical geneticists in the United States, which equates to about 4 per 1 million people in the population. Yet there are an estimated 2 to 5% of the population with either a genetic condition or congenital anomalies that would warrant a visit with a geneticist. It is just not possible for 4 people out of 1 million to see those 20,000 to 50,000 people who might be affected. We've got to share the load. And likewise, in medical schools now, genetics is more a part of it, but still, with all of the breadth of knowledge that different medical specialists have to learn, they get maybe 5 or 6 lectures on genetics. That's simply not sufficient to be an expert. So where we come in and our view on the lab side is let's use our expertise to really come in a targeted way to help the patient.
Yeah, that makes sense. There's a lot of pressure in this country to push more and more care to less educated providers, so nurse practitioners, physician assistants. And without any criticism of their important role in the healthcare system, they get even less training in things like genetics than, say, a primary care physician. So it's fantastic that people like you are available in the loop. I'd love for you to walk through some cases. I understand you brought some patient cases with you that illustrate these issues. The first one, I believe, involves cystic fibrosis carrier screening. Based on my limited knowledge of CF carrier screening, the panels that are offered are fairly standardized across different laboratories. So I would think this should be a straightforward case of the doctor just picks the test off the list and orders it. What was the mystery in this case, and what kind of detective work was involved in solving it?
So for this case, and this is one I completely made up, this is a theoretical patient who comes in, a pregnant woman who is speaking with her OB about cystic fibrosis testing. She has a brother who's known to be a carrier of CF. The brother lives far away. The brother doesn't have access to his report. The OB is really used to ordering cystic fibrosis carrier testing. This is a common mutation panel or common variant panel. So the OB thinks, okay, I don't know the brother's mutation. However, I have ordered carrier screening on my white patients in the past, and I know that the panel is quite good at detecting carrier status if it's present in white patients. So they go ahead and order the cystic fibrosis common variant panel. It comes to the laboratory, and someone on my team, a fellow genetic counselor, looks at the order and raises a red flag. They're like, wait. The mystery, we got to solve this mystery before we move forward of what is the brother's mutation. And you might say, well, we're probably going to detect it on the common variant panel. The answer is it might be on the common variant panel, but it might not be. So in this theoretical example, we really push on the lab side, we push the clinician and therefore the patient to get the brother's results. It takes a lot of phone calls. It's frustrating. It's annoying. There are releases that have to be signed, and it's really difficult to find that brother's report. But good thing we did, because you can guess the punchline. The brother's mutation was not on the panel. So in solving what the mutation was, we've also helped to solve what's the best test. If you think about it, if the patient had not had us there, we just ran the common variant panel, the patient's result would have been negative, because we know the brother's mutation is not on there. The patient would have falsely thought that she was at a low, maybe even zero risk. She would have managed her pregnancy accordingly. But now that we've stepped in and solved this, we can really get to the bottom of what is the right test for this exact variant, so that regardless of the result, the patient knows they can trust that answer.
So it sounds like the key take-home lesson here is that if there is any genetic knowledge on the patient side at all, particularly involving family history, that it's critical to know that before you start undertaking testing.
Absolutely. That's the ideal.
Okay, so I understand you also have another case that has something to do with gestational diabetes. I am not personally aware of any genetic workups that are routine for gestational diabetes. Enlighten us.
Okay, so this patient was someone who, I'm going to start in the middle on the lab side. We get a new order for a chromosome test, so a chromosome karyotype, for an adult woman, a pregnant patient, where the reason for testing was given as gestational diabetes. You're absolutely correct. There is no common workup, no reason really to think of a chromosome abnormality when someone has gestational diabetes. That was flagged for us, and we called the provider. The mystery at first was, what's the real story here? Come to find out that gestational diabetes diagnosis was put in because it happened to be an ICD-9 code that was present in the patient's chart. Since chromosome analysis is a genomic test and there are lab requirements that we have to have a diagnosis, and the client knows we have to have a diagnosis, They gave us what was conveniently available.
They gave a diagnosis. They
Exactly.
didn't give the relevant diagnosis.
Exactly. And the folks who were putting in the diagnosis, no judgment on them. They're just trying to do their job. They have hundreds of samples, and they may not understand the relevance there. So when we called the provider, part of the mystery that we were able to investigate was, okay, this is, again, a family history situation where this woman had a younger cousin with intellectual disability, various medical issues. That cousin had had a genomic microarray that was abnormal. That child's parents had had testing because of the nature of the finding on the microarray. And the woman's aunt was found to have a translocation between 2 chromosomes. So all of the genetic information is present in this aunt, but some of the chromosome material had swapped places. With that in mind, that puts our patient, our pregnant patient, at risk to also carry the same translocation. If she does, then there could be a risk to the unborn baby. As with the last case, we insisted on we've got to really investigate and sleuth out what is the familial translocation like here. Because you've ordered chromosomes, that's good. That's often a test that can identify if there's a balanced translocation, but we've got to double check. So our genetic counseling team dug deeper, were able to get a copy of the aunt's report, and it turns out on the aunt's report that the segments of DNA that had swapped were teeny tiny and could not be identified by a standard chromosome karyotype, which takes a really zoomed out bird's eye view of the chromosome. So a teeny little swap might not be visible, as in this case. And so some additional testing was needed in order to give her a yes or no answer. Walking through this one again, if we had not solved the case in this way, with the lab genetic counselor involvement that like we had, then the patient would have had the chromosomes run. She would have probably had a normal result. You and I know we wouldn't have answered the question, but she would have been falsely reassured in thinking that her fetus is not at risk because she does not, quote unquote, have the translocation. Taking it to an extreme, maybe that means she would not have tested her fetus. There would have been no reason to. Maybe she would have decided to deliver baby at home. That's not uncommon. And then maybe fetus would have actually been affected with an unbalanced translocation, had a ton of medical issues at birth and required an urgent stay in the NICU, or maybe not even have made it to the hospital. That's super extreme, but it is theoretically possible, which is why we feel so passionate about getting to the bottom of these mysteries when they happen.
Yeah, obstetrics is definitely a field where when things go badly, they can go really badly. I can also imagine that if she had had that baby, and if the baby had had, severe medical problems at birth, that having a false negative diagnosis could have misled the treatment team into not investigating. So it really could play out at multiple levels here.
Mm-hmm.
There's a third case that you mentioned, which this one just sounds crazy because it has something to do with bunions, and I'm pretty sure that there's not a genetic test for bunions. What was going on this one?
I made up the diagnosis of bunions, but this happens all the time where we get, just like the last case, we get sort of a red herring diagnosis that's there for convenience, but doesn't reflect what is actually going on with this patient. So here again, we start in the middle at the laboratory end, where this time we've got a genomic microarray that's ordered on an adult male with a diagnosis of bunions. We are reviewing these orders, and that flags us as, I don't know if this is the right test. There's got to be more to this story going on an adult male for a microarray. Maybe they're thinking about cancer. Maybe they need a totally different test here. But as we do, we investigate with the ordering provider to try to figure out this mystery of what might explain this. And when you call, you never know what direction you might go in. You just kind of need to be prepared for anything. But when we called the provider to investigate, we found out that this microarray had been ordered because this patient was a father of a child with a common deletion syndrome called Cre du Chat, which is a deletion on the 5th chromosome at the terminal end. And the clinical question from the provider was, is this father at risk to have another child with Cri-du-Chat syndrome? The other piece of the puzzle that we insisted on getting because we knew we needed the report, when we got the report about Cri-du-Chat syndrome, we found out that it's not just a deletion on chromosome 5. This patient actually has a deletion that's caused by a translocation, another swap between chromosomes 5 and 4. So that changes how we approach the question in that case. When we talked with the doctor about it, the doctor said, well, but the child was diagnosed with this unbalanced translocation and Cri-du-Chat syndrome with a genomic microarray. Why can't we just order a genomic microarray on dad like we did for the child? And that really comes down to understanding the limitations of what these tests can or cannot provide. Even though they're genomic tests, you're looking at the whole genome, but there are still limitations in what it can answer. And in the case of looking for a balanced translocation in a father, microarray won't work. In our last case, we learned that when you have swapped chromosome material, maybe you can do chromosomes. In this case, as with the last case, those swapped segments were really teeny tiny. So we were not able to feel confident that chromosomes could answer the question. There's one more test up our sleeve, and that's FISH testing, or fluorescence in situ hybridization, which I tell you not because the audience needs to remember all these details, but just to understand the nuance that goes into all these tests. There is a common commercial FISH test for Cri-du-Chat syndrome. And at first, internally in our investigative team, we were thinking that we were going to have the answer. But the genetic counselor on this case astutely observed and really pushed to clarify we must have information about the breakpoints. For this case, and I know this is a rare case, but it did truly happen, so it's important to address. It turns out that the deletion that the patient had does cause symptoms for Cri-du-Chat. This patient does have a clinical diagnosis for Cri-du-Chat, but that FISH test, the probe that we need, does not bind in the deleted region. It binds just outside, meaning this patient had Cri-du-Chat with atypical breakpoints, and because of that uniqueness in the breakpoints, it means the FISH test couldn't be used. So in the end, the genetic counselor was able to find a better option, subtelomeric FISH, for those who are really interested, but it highlights something that even your clinical geneticists aren't going to have the bandwidth to keep on top of. And it took us a lot of effort to find out the location of the FISH probe breakpoints in comparison with the deletions. It just kind of goes to show that you've really got to have a collaboration between genetics experts at the laboratory and the clinical folks who know the patient.
So it sounds like the potential patient impact in these cases can be pretty significant.
Yeah, what I've talked about today with some of these cases is related to pregnancy and recurrence risk. Of course, the human impact there being that there might be a child born with a serious condition that, number one, the parents were not expecting nor prepared for, but number two, that they had been told specifically they were not at risk for. That's one big area. The other big area is you may lead to shortening someone's lifespan with some of these familial test misorders. If the disorder in question was an inherited cancer syndrome, for example, and the wrong familial test had been ordered, and the person who's at risk for cancer now thinks that they are at low general population risk, when in fact they were falsely reassured by the wrong test, you can imagine that they would not get the screening. They would think they're off the hook. They might have a cancer diagnosis diagnosed too late and end up shortening their lives. This is something that ends up being really critical for these patients.
So these are very high-stakes decisions.
That's exactly right.
It sounds like there may be some categories of genetic testing that are particularly prone to misordering. or more prone to needing additional investigation? What are sort of those main categories?
Sure. I think familial testing is the biggest, heaviest hitter, and that's what my case examples relate to. It's really difficult, especially for structural variants, the ones that are not sequence-based, and where the methodology that's needed for a relative is different than the methodology that was used for the proband. That is a big area of potential misorders. And other areas would be when you have testing that sounds the same, like galactomannan, which is not genetic, compared with galactosemia, which is a genetic condition. I don't know how that misorder happens, but sometimes it does, just kind of because it sounds the same. Maybe they're near each other on the alphabetical list. Others would be where there are multiple options for the same methodology. I mentioned fish in one of our examples. There are multiple options for fish, whether on the constitutional side, on an oncology side, and that can be difficult to choose, or when there are multiple options for one condition, a large gene panel, a multi-gene panel, versus a targeted variant panel. Those kinds of things are all ones that are prone to misorders.
So you mentioned structural versus sequence variants, and I'm interested in having you elaborate on that a little bit. My preconception is that ever since the Human Genome Project a couple decades ago, everyone thinks that everything in genetics has to do with sequence, and also that everything is pretty much solved.
Right. That's a fair question. And it's true in the genetic sphere, a lot is based on sequence variants. The Human Genome Project was critical for our time because it mapped out the human genome. We didn't really understand what exactly was there before. Now we understand a lot more the sequence of the human genome, or at least the quote-unquote normal reference. Something that the Human Genome Project didn't do is figure out, okay, now we know there's a gene here. How do we know what it does? What if we change a few of the base pairs within that gene, sequence variants? What does that do? What's the implication there? Not answered by the Human Genome Project. What about if we delete part or all of that gene? What is that going to do? Not answered by the Genome Project. Or duplicate. What if it's switched around? What if all sorts of different things? What if the enhancer elements related to the function of that gene have some sort of change? None of that's answered by the Human Genome Project, but the Human Genome Project gives us the framework for where to proceed and learn more about what is going on. The other thing about genome, we've talked about genomic medicine. A big test that's out really popular right now is whole genome sequencing or whole exome sequencing. There again, you are dealing with sequencing, decoding the letters of the genome or genes. What you're not doing is finding copy number variants or structural variants, which means something where there's a deletion or a duplication or a rearrangement in some way. Sometimes a chromosome can get inverted, and that won't be visible by some of these sequencing platforms. To make things a little more confusing, some folks, when they offer whole genome sequencing, they also pair it with a methodology that can give information about deletion and duplications. Some don't. So it's really up to the provider and the experts ordering the test and interpreting the test for their patients to really understand what was and wasn't tested. So even though whole genome sequencing can look in depth at every coding gene, you still might not have all the answers, and you still might need a different genomic test, like a genomic microarray to find deletions and duplications, or a genomic chromosome analysis to look at a karyogram and get that bird's eye view of the chromosomes.
There's definitely no way that a typical family practice or general pediatrician is going to keep up on all this. This just sounds way too complex. Okay, so let's talk a little bit about the group that you work with and the laboratory utilization management, or sometimes this gets referred to as laboratory stewardship. So I know this is a common role for genetic counselors to be in. But could you sort of lay out the landscape? How many laboratories even have genetic counselors to do this kind of review, and how does the review work?
Yes, you are right. There's a lot of effort made on the part of lab GCs for utilization management or lab stewardship, as you say. I think utilization management was the original term, so we've used it a lot, but really lab stewardship is what we're doing. We're stewards of the testing, advocating for patients and the best patient care. In terms of the number of labs who have genetic counselors, I don't exactly know, but I know more and more there are both genetic counselors at these laboratories performing the genetic testing and genetic counselors at the clinical institutions who are ordering the genetic testing. So I think that number is increasing, and I hope that it's most laboratories.
I would certainly hope that a clinician ordering this testing would be aware of whether there was a genetic counselor in the loop.
Yeah, hopefully, but sometimes I think providers might not know they have resources on their side at the laboratory. And our genetic counseling team is great, but even for laboratories who don't have genetic counselors, there's always going to be a medical director. So if there are questions, there's going to be resources. But I really think genetic counselors are best suited for roles in lab stewardship for genetic testing.
How many of the issues that come up are detected after the order is received, as opposed to the clinician calling you up in advance to ask, what should I order?
It's hard to answer because when I have a conversation with a provider about the patient that's in front of us right now, I'm actually educating the provider, and it might have a ripple effect on the rest of their practice. Or if I can speak with a colleague, they sort of get the word out amongst their team and go from there. So I think the lab stewardship systems in a genetic testing lab are going to be different. And they're really different depending on the methodology. What I mean by that is sometimes you can set up really simple automatic measures to get at lab stewardship. Maybe you just need to set up an age cutoff or a duplicate check. For us in cytogenetics, where it's that genomic testing and we are really reviewing all of the orders, I just want to stress the importance of the collaborative approach. So it's the genetic counseling team, the support specialists, the lab supervisors, and medical directorship who get together and figure out what makes sense for workflow, what makes sense for the processes that we have and the misorders that we're seeing to implement in terms of stewardship. And what works fantastically well at ARUP is having a tiered approach. We rely heavily on our genetic counseling support specialists to review every order that comes in. They're the ones who would flag the bunions and the gestational diabetes and the family history of such and such. They flag it for us, and the genetic counselors then take the ball, and we will reach out either internally to supervisors, as in the case where we needed to figure out the breakpoints of that FISH probe, or if there's a complex question technically that we're not able to answer. We also collaborate with the providers directly. Everybody's well-trained. The staff are meticulous. The folks who help fix the test orders, that's another group that's really critical to our team. The genetics processing folks, once we know what kind of test we want to change it to, getting that done correctly and efficiently is super important, in addition to having access to those clients and providers.
So in the big picture, for the kinds of genetic testing that we're talking about, do you have a sense of about how many of those orders end up getting flagged and how many of those orders might be incorrect if not reviewed?
In terms of like what we review and what gets flagged, I don't have exact numbers. A lot of things get flagged and they're okay to proceed. Mm-hmm. My gut is that maybe we're on the order of like 10 to 20% of cases that need additional investigation by the GC team. There have been some studies of lab GC roles and misorders in the laboratory setting, and in a very global sense, the misorder rate is on the order of 20 to 25%.
The other part of the healthcare system that uses the word utilization a lot is on the payer side, with utilization review, utilization management, that kind of stuff. where, let's just be honest, the explicit intent there is saving money. It sounds to me like the review that you and your team do is not narrowly restricted to saving money, but do you have a sense of whether these kinds of activities do save healthcare costs overall?
Yeah, I would argue that when you change a test from an incorrect or not as good test to one that's the best test, you have saved the cost of that incorrect first test. Whether the second test is more or less expensive is irrelevant in my personal view. So from that standpoint, absolutely, we're saving money for the healthcare system. We're saving money for the patient. That's part of our mantra in taking care of these patients and getting them the best test, is to avoid those wasted costs, time, money, and angst in getting the wrong one. There have been some studies of this. So we did a study way back in 2014 to get at this, but since then, other entities have done similar studies and shown that genetic counselor review of genetic test orders saves thousands of dollars every month, depending on the size of the institution, of course, and how many FTEs you have associated. But on the most part, the studies that I have seen, the genetic counselor review saves the ordering facilities a lot more money than the cost of the genetic counselor's salary.
So this makes sense, especially given that a lot of genetic testing is on the expensive side, if you think about the whole spectrum of laboratory tests. The point that you made a minute ago, I think, is worth reinforcing. If I understood you correctly, you're saying that if you review an order and it turns out to be incorrect, and so you redirect the order onto a different test, regardless of whether that second test is more or less expensive, it's going to be necessary anyway, whether that's discovered now or down the road. And so either way, you're saving the cost of whatever the original order was, correct?
Yes, that's my view.
But then aside from the testing costs, I'm imagining that some of these scenarios could involve an extensive diagnostic odyssey. So if you're talking multiple clinic visits and doctor time and everything else, don't some of these patients, especially with rare genetic diseases, sometimes go a very long time before the answer is discovered?
Yes, that's correct. Especially when we have a lack of genetics professionals who can see these patients in clinic, it's left to the family care, the pediatrician, neurologist, cardiologist, endocrinologist to try to sort this out for patients. And being able to put our heads together and consult on what the specialist's expertise is about the patient compared with what we know about genetic testing can really be valuable. And that's where, of course, the genomic testing comes in, where if you suspect a genetic condition or a genetic cause for a patient's symptoms, but the provider doesn't have a specific genetic condition in mind, doing genomic testing can be the best test, even though it's the most expensive.
Do insurance companies understand this, or do they put a lot of restrictions on ordering things like genomic testing?
You're asking someone who works in a laboratory that does not do third-party billing. So with that caveat in mind, my understanding is that there are very smart people on the insurance side, including genetic counselor trained individuals who are working to make the insurance system smarter and better for genetic testing, working to get appropriate genetic tests approved and make sure that the healthcare dollars are not spent on inappropriate genetic tests. Beyond that, my fingers are crossed.
Well, I hope you're correct on this.
I hope so too.
So this actually brings up a related, sort of overlapping health economics question. When you look at what's going on in the healthcare landscape today, particularly in health systems, hospitals and health systems are pushing the provider side to be, quote unquote, more efficient. So from their perspective, it means see more patients per hour, spend less time with each patient. I don't know whether they're applying the same thing to genetic counselors, but I have to imagine that genetic counselors are probably under pressure to do more cases per hour. But couldn't this hit a point where it's counterproductive? If you're expecting doctors to spend less time per patient, that's less time for this kind of problem solving and investigation and detective work that you're saying would actually save money if you do it up front.
Right. I think that's the crux of the issue is genetic conditions are complex. They take a thoughtful approach. They take someone with lots of in-depth expertise. If you've got folks, including the geneticists and the general healthcare providers who need to rush and see as many patients as possible, they're going to increase the time of the diagnostic odyssey for that patient. They're going to increase the cost overall because they'll see a symptom, order a test for that symptom. See another symptom, order another test for that symptom. And there's not going to be this comprehensive, holistic approach that can address all the symptoms at once. Are they related or not? That takes the more thoughtful approach. Also, when you order all those tests, is that provider going to know what the results mean? What if you get a variant of uncertain significance? There's published studies that folks who are not genetically trained may misinterpret. They may over or underinterpret what a variant of uncertain significance means, which also has harmful impacts on patients and the follow-up testing that they and their family members might have. So thus increasing costs. It just seems to me like in this push to make healthcare workers more efficient, we need to increase the collaboration and really be less siloed. We need more genetic counselors, obviously. I just want to mention the team approach to this stewardship initiative. We have a lot of support people who are excellent, and utilizing those support folks for the maximum that their skills can offer really frees up time for the genetic counselors to work at the top of my scope, which then in turn helps the limited clinical geneticists to work at the top of their scope. So I guess it's a pie in the sky ideal, but if we can be more collaborative and have easier access to have these mini consults together, I think it would really improve the system overall while still accomplishing the goal of being efficient.
I agree. This is just incredibly important, and it's one of the major things that seems to be failing in American healthcare right now. But one aspect of collaboration is the way that information systems are used to manage the information flow. We talked at the beginning with these cases that when you receive a test order, it's received electronically. It's an HL7 message for those who are into that sort of technicality. And there's a little textual field for the diagnosis. And you pointed out how that doesn't always work very well. Now, you're working in a reference lab setting. I'm sure you've talked with colleagues who work more in a hospital setting where they may have more access to the health records. But could you comment on how the extent to which electronic health records are either helping or hindering the kinds of collaboration that you're pointing out is so important?
I think for the most part, the EMR or the electronic medical record systems have really helped in communication. Yes, we get those aberrant ICD codes that are true to the patient but not relevant to the genetic test. True, we get those. But we also see providers who utilize those to great efficiency and advantage for us, where they say exactly what we need to know. It takes them 2 seconds to type out, and we're golden. It is a little difficult sometimes to get in touch with them directly. And so their clinic staff is also trying to do what they can to help us. I'm calling them, interrupting their workflow to try to, hey, help me dig into this and solve this mystery. I can't do it without you. And they don't know exactly what it is that they're looking for. So they'll either read through the entire clinic note or send us the clinic note. That is often helpful, not always, because sometimes you get a 15-page clinic note and it still doesn't necessarily talk about the rationale for ordering the specific genetic test. But I think overall, utilizing the EMR to our advantage is where we're going to find more success. I remember in the original days here at ARUP where we would get scanned images of a handwritten note that the doctor had written.
And then you had to decipher it?
Yeah. And then, well, we didn't decipher it. The poor send out person is trying to decipher it. And then maybe that send out person had to send the sample to a secondary institution. That secondary institution is the one ordering the test from us. Meanwhile, the physical copy of that handwritten note is nowhere to be seen, and we get absolutely no paperwork whatsoever. This certainly still happens, but there are a lot of success stories, and I think the EMR is to be applauded for that. And I think the EMR is probably the way we can go in the future to facilitate more efficiency.
And it also sounds like you're saying that there are some opportunities there for EMRs to both have higher quality information, like not the 15-page, cut and pasted clinic note, but maybe also supports more of the communication processes so that you're not having to get on the telephone so much.
Right. Yeah, I could see that. Especially, wink, wink, if we could just get access to EMRs directly, that would help a lot too.
So that brings up another point. And again, you're in a reference lab setting where you're separated from the health system where the patient is. But I can imagine that this may be a common scenario even in other settings. For example, suppose you need a family member's medical records, but those family medical records are in a completely different EMR system because they live in another state. So do these sort of cross-health system data sharing issues come up?
Well, they come up in the fact that we don't have access, and it's painful, time-consuming, frustrating to connect those dots, especially because everybody is doing their best, rightly so, to safeguard patient privacy.
Absolutely.
And just because a relative has a genetic finding, they may not want to share that with their relatives. So that's a dynamic that's addressed on the clinical side in genetic counseling, but because of that, understandably, the facilities who have the relative's result might hold on tight to it and require things like a release signed by the patient. And me coming in as a totally third or even feels like a fourth party, 4 times removed from the direct patient interaction, I am definitely not someone who's typically granted access to that without a lot of homework. So in terms of your question, I would love if we had some sort of centralized repository for these types of things, that we could get access without infringing on patient privacy.
I wonder if we need a national infrastructure for patient consent. If we could make the sort of the consenting and the granting access part more efficient, maybe we wouldn't have to jump through so many hoops.
That's a fair statement. That's sort of like outside of what I do on the day-to-day, but I could see that working well. Patient consent is another category where genetic counselors get involved on the clinical side a lot and on the research side. It's important that that consenting is done really well and thoughtfully, but hopefully with electronic means that can be implemented more efficiently as an idea.
Okay, so final question. You've worked in healthcare a long time. You've worked on different kinds of diagnostic problems, all genetic related. If you had a magic wand to wave at the American healthcare system and make mystery solving and detective work just work better, where would you point that magic wand first?
Well, you're asking someone who has very little influence on the nationwide healthcare system.
We're all in that category.
Yeah. So in terms of low-hanging fruit and the mystery solving aspect, if I could have more accessible access to the providers directly, if I could easily know who the provider is and message them directly, I would love that. So I see that as an electronic
communication with the provider.
Electronic communication means if I could influence the culture of healthcare so that there is less siloing and a lot more, hey, I'm going to order this test. What do you think? This is what I'm looking for. Is this the right test? Great. If not, let's work together on how can we get at this? What are the possibilities? So more of that pre-test provider to lab consultation would be fantastic. In general, I think it would be worthwhile to have more provider to provider consultation. Yes, of course, the lab GCs are here to help providers, clinic staff, send out folks with their genetics questions, but maybe clinical genetics folks can work together there too. Maybe the clinical genetics folks can collaborate more efficiently with the counterpart specialties that affect their patients with genetic conditions. And I know that that's already happening successfully in various institutions, but if it could be more universal, I think that would be really, really good. I think having more people like me, more genetic counselors, more of the folks who help with our stewardship initiatives would be really, really helpful for some of the reasons I mentioned before, just helping everybody work most efficiently at the top of their scope. But in order to have more GCs, we got to address that we need better reimbursement for genetic counselors. We need smarter reimbursement for familial tests so that we don't run into obstacles and hurdles trying to get the right test for patients. In a pie-in-the-sky way, what you mentioned about some sort of national repository, national communication effort for all healthcare providers, that would be great. I certainly don't have ideas on the how, but if it were there, that would just be a wonderful thing.
Well, as an American healthcare system, we have an ambitious to-do list.
I think so.
Thank you so much, Amanda Openshaw, for joining us on LabMind today.
It's been a real treat. Thank you.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta-Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.